Welcome again. My name is Jenny Stern-Carasone, and I am the Associate Director of the Children's Safety Network and the Director of the Child Safety Learning Collaborative, affectionately referred to as the CSLC. Today's webinar is the Children's Safety Network webinar on Child Safety Learning Collaborative, Together We Are Stronger. The Children's Safety Network is funded through support from the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under the Child and Adolescent Injury and Violence Prevention Resource Centers Cooperative Agreement. I'm going to now hand this over to my colleague Kate Sinclair to share a few technical tips to ensure a smooth ride for all today. Kate?
Thank you, Jenny. So if you can hear me right now, you'll notice that the audio is being broadcast through your computer speakers. The quality of the audio is dependent upon how good your internet connection is. So if you experience audio issues throughout the webinar, you can dial 866-835-7973, and please make sure to mute your computer speakers. You are muted. You will be muted during the rest of the webinar. Please use the Q&A pod at the bottom left to ask questions at any time. You'll see up at the top left is our file share pod where you can download today's slides. And this session is being recorded and will be shared with all of our participants. Back to you, Jenny.
Thank you, Kate. Once again, we are very honored today to have 4 representatives from our CSLC teams joining us today to share their experience and benefits from being part of the CSLC, especially over the past year. Nicole Cousins and Jane Herwicke are joining us from the Louisiana Suicide and Self-Harm Prevention Team, Terry Miller from Georgia's Sudden Unexpected Infant Death Prevention Team, and Brittany Willis from the Tennessee Suicide and Self-Harm Prevention Team. You will hear more details about each of these presenters later on when we introduce them to share about their work and their collaborative experiences. Today's webinar will provide a brief overview of what the CSLC is and how it works to support state and jurisdiction Title V work. Then we'll spend most of our time hearing from our CSLC participants about how peer sharing helped improve their injury and violence prevention efforts. And finally, I'll return to share some forecasting on the upcoming opportunity to join the Cohort 3 of the CSLC. Let me tell you a little bit about Children's Safety Network. The Children's Safety Network was established through funding from HRSA's Maternal and Child Health Bureau in 1990 and is the Bureau's primary vehicle for providing technical assistance to Title V agencies on injury and violence prevention. We utilize a wide variety of mechanisms to achieve this, including our national partnerships, the Children's Safety Now Alliance, technical assistance, and webinars, resources, and publications that we share via our website. Today we're going to share some highlights from another facet of this comprehensive work, the Child Safety Learning Collaborative. The Child Safety Learning Collaborative's aim is to reduce fatal and serious injuries among infants, children, and adolescents through evidence-based practices in the application of quality improvement methods. Teams are working on select injury topics of areas that were identified by HRSA, the Children's Safety Network, and the Children's Safety Now Alliance as areas with the highest need and that are ripe for improvement. The topics in Cohort 2 are bullying prevention, motor vehicle traffic safety, which includes both child passenger safety and teen driver safety, sudden unexpected infant death prevention, and suicide and self-harm prevention. Teams that are participating in the CSLC come together to use the CSM framework for quality improvement and innovation in child safety. We will share a link to the recent publication on this approach in the Q&A pod for you all to access, and it is published and available on our website. The CSM framework focuses on building public will and state jurisdiction capacity in key areas essential to achieving sustainable and scalable child safety results. Cornerstones of our approach to capacity and coalition building include identification and use of data-driven, evidence-based, and evidence-informed strategies and programs, increased effectiveness of management and leadership, and ongoing commitment to shared learning and principles drawn from advances in improvement and implementation sciences, such as change packages and plan-do-study act cycles. The CSLC serves as a testing ground for these approaches, so that we can later share these resources with the larger public. Some of our comprehensive change packages from earlier collaborative work are already posted on our website and available for use. The CSLC consists of 3 cohorts over a 5-year period, with each cohort lasting approximately 18 months. State Title V agencies or designated partners apply to join the cohort and participate on a voluntary basis. Throughout the cohort, state strategy teams work on selected evidence-based and evidence-informed strategies, collect and report monthly data, and attend monthly calls to learn from one another and receive targeted technical assistance. As you can see, we are in the middle of Cohort 2, and we will begin recruiting for Cohort 3 this summer. In Cohort 2, we had a large number of our Cohort 1 states continue into the new cohort, some even adding new strategy teams addressing additional topics. We also welcome 4 new states to this cohort: Florida, Georgia, Kentucky, and Missouri. The impact of COVID-19 on almost 100% of our CSLC teams resulted in team members being reassigned to COVID-19 related duties. Sometimes this lasted several months, and sometimes it was recurring, often leaving the CSLC team without leadership and sometimes without even any active members. In addition to these staffing challenges, the additional impact of natural disasters also resulted in logistical turmoil, such as the loss of key partner alliances because of the need to shift priorities. The CSLC aimed to provide several means to assist states in weathering these challenges throughout 2020. For example, we prioritized time in our topic calls and learning sessions to provide ample opportunity for teams to share the various challenges and successes and lessons learned, and to build a sense of common shared experience with one another. Teams were also able to draw from the change package strategies to identify new options, organize their strategic approach into manageable components using quality improvement tools, and leverage new and existing partnerships to pivot their work. CSN integrated feedback and experience from participating teams to create new tools, helping states align their CSLC work with existing work under their Title V State Action Plan. We are also developing a health equity planner tool that will support assessing and incorporating health equity in programmatic and organizational levels. All in all, our experience throughout the cohort affirms the resilience of Title V agencies. I want to share a few examples before we move on to our presenters. Throughout 2020, teams had to pivot their work in response to the changing circumstances. One such pivot was the adaptation of evidence-based trainings to a virtual format. Some examples of this include in Pennsylvania, their bullying prevention work with Clemson University adapted the Alveus Bullying Prevention Program for community youth organizations trainings to a virtual platform. In Wisconsin and Washington, their MVTS teams converted child passenger safety technician training and certification to a virtual conveyance. In addition to the work that you'll hear about later, the Georgia Sudden Unexpected Infant Death Prevention team also created a virtual training for home visiting programs. And Tennessee Suicide and Self-Harm Prevention converted to an online version of the Question, Persuade, and Refer Gatekeeper training, which you'll hear more about later as well. Furthermore, we saw across this cohort resilience in the ability to add new methods and procedures to convert face-to-face activities to COVID-19 parameters. In Wisconsin and Florida, MVTS teams developed curbside cart seat distribution and video installation instruction. Pennsylvania Sudden Unexpected Infant Death Prevention adapted their outreach and safe sleep training of hospitals and developed supplemental online education resources. Other examples of teams adjusting strategies and focus in response to disruptions such as COVID or natural disasters included in Nebraska, their MVTS team responded to the loss of schools that were doing teens in the driver's seat classes by turning their focus to creating virtual driver education modules and resources for schools to share online, getting graduated driver licensing standards incorporated into their DMV handbook, and working on improving how law enforcement communicates traffic safety information. Additionally, as you'll hear more about in a moment, the impact of COVID and hurricanes on the Louisiana Suicide Self-Harm Prevention team forced them to shift from focusing on valid and reliable suicide risk screening tools in schools and healthcare settings to a virtual gatekeeper training. We also saw many diverse partnerships represented across this cohort. The Texas MVTS team worked with their car seat distribution funder to adjust the criteria in response to the changing circumstances due to COVID and allow them to continue distributing car seats. In Wyoming, they launched a youth advisory board to ensure that their efforts in suicide self-harm prevention and teen driver safety were meeting the community needs. Some examples of the diverse partnerships featured included community-based organizations and school districts, statewide coalitions, hospitals, state departments, and creating youth advisory groups. One of the core tenets of the CSLC is the all teach, all learn principle. The CSLC is designed around this core value, and it's amplified through our member-only web portal, collaborative mailing lists, monthly topic calls, and periodic collaborative-wide learning sessions, where we are consistently encouraging teams to share seamlessly and steal shamelessly from one another. We are now going to hear from several teams about this prevention work and how the model has enabled them to advance their child and adolescent injury prevention work. At this time, I'm going to hand the mic over to my colleague, Maria Katratis, who is our topic lead for the CSLC Suicide and Self-Harm Prevention Team and our data manager, and she will introduce the speakers and share some more information. Maria.
Thanks, Jenny. Hi, everyone, and thank you for the opportunity to speak about our experience in the Suicide and Self-Harm Prevention Team. We're going to have a slightly different format. So, our participating states have been so incredibly supportive of one another and have really encouraged each other to keep going and to keep improving their processes during this incredibly challenging year. This is evidenced not only in the peer learning and peer sharing that we'll chat about today, but also in the open dialogue with one another on our topic calls, in sharing resources and reports, and in pushing the envelope in child and adolescent suicide and self-harm prevention nationwide. At the end of the day, what each team gets out of our all teach, all learn approach in the Child Safety Learning Collaborative is up to the participants. They truly get out what they put in. Their willingness to share and teach others is honestly absolutely inspiring. Today I have the privilege of chatting with Brittany Willis, Jane Herway, and Nicole Cousins about their collaboration working with syndromic surveillance data related to suicide and self-harm. Brittany Willis is the Suicide Prevention Program Director at the Tennessee Department of Health. She is the current leader of the Tennessee team in the CSLC. And Nicole Cousins and Jane Herway are from the Louisiana Department of Health, Bureau of Family Health. Jane is the Injury Director, and Nicole is the Program Assistant and current leader of the Louisiana team in the CSLC. During a number of topic calls, Brittany had mentioned their use of the electronic surveillance system for the early notification of community-based epidemics, also known as ESSENCE, to track suicide, suicidal ideation, intentional self-harm, and also to alert authorities that their communities are at risk. Jane and the Louisiana team had begun their own journey into the use of syndromic surveillance, using emergency department surveillance of non-fatal suicide-related outcomes, also known as ED Censorum. This led to a month-long and ongoing fruitful collaboration, which began with a bonus topic call for all of our participating states, and specifically focusing on the use of syndromic surveillance to track and alert communities about youth at risk of suicide. Thank you all so much for taking the time to speak with us today. If you could all join us, please. Wonderful. Thank you all for being with us today. So Brittany, can you tell us a bit about ESSENCE and what you're doing with it?
Yeah, sure. So ESSENCE is a syndromic surveillance system that allows us to collect data from an emergency department. So it tracks patient chief complaint data and discharge diagnosis data. So we're currently using the syndromic surveillance to track suicide-related emergency department visits in children under 18 and those 18 to 24 across the state. So we're doing this surveillance weekly, and we're looking for visits including intentional self-harm, suicide attempts, as well as suicidal ideation, so those thoughts and feelings. And what we're doing with that is we've created a response plan. So we are notifying individuals within regions and counties across the state, seeing an increase each week to help them, spread awareness within their communities and share resources for those who may be struggling.
Oh, I'm sorry. Jane, could you tell us a bit about how you learned about what your peers are doing in the suicide and self-harm prevention team?
Sure, and I think it was one of those topic calls where Brittany presented on what they were doing with Essence data. And you guys, when we use the terms ED-Censro and Essence, that's really the same thing. So ED-Censro is the name of the project, and Essence is actually the platform or the sort of data source. So it was on a topic call, and we have Louisiana has a very close working relationship through not just HRSA and the Maternal Child Health Bureau and the Children's Safety Network, but also through CDC injury projects with our injury colleagues in Tennessee. So we were excited to hear what Brittany was doing because we had recently, as Jenny alluded to earlier, had switched from focusing on valid and reliable screening in emergency departments to working with QPR as gatekeeper training. That was our backup sort of technical package. And like Tennessee, we also have virtual QPR training through one of our partners. So when we heard what Brittany was doing about how she was really using the Essence data and the warnings and alerts that come through Essence to alert folks at a regional level about what was happening with, children, youth, and young adults in terms of suicide, we thought that's something that we were very interested in doing. So it became a quick reach out to Brittany, and Terry connected us, I think, and then our communications specialist who works on our ED-Censro or our Essence project really quickly, got some information, and the epidemiologist from Brittany on how they kind of package the information. And so we are doing something very similar where we're looking at alerts, and then we're pushing these alerts out really at this point only to behavioral health specialists and leaders in our adolescent school health clinics around the state, and also pairing that with resources for suicide prevention and gatekeeper. And Nicole kind of coordinates a lot of our virtual QPR, or question, persuade, refer training that's going on now. So it's pretty much a similar model. There are a few nuances there, but just through, the calls, and then the fact that because we participate in the learning collaboratives and so many other sort of network meetings, we feel like we have that ability to just, call up the other team and say, hey, let's talk about this, and it really pays off. So.
Wonderful. Brittany, could you share with us what you shared with Jane and the Louisiana team about your process and what you've been doing?
Yeah, sure. So initially through conversations, we really kind of just shared what this surveillance is in more detail. We shared some of the ICD-10 codes, and then through further meetings, we shared the Essence Rapid Prevention Response Plan that I have worked with stakeholders across Tennessee to create in response to these Essence alerts, as well as some of the emails that I send these stakeholders each week when we are seeing increases within their counties or regions.
Great. And what was it like for you to lead our extra call? So as I mentioned in introducing all of you, this request that came from Jane actually facilitated our extra call. So during the Child Safety Learning Collaborative, each of the topic teams meets on a regular basis, and we had a bonus call that was focused specifically on this. So what was it like for you to share and lead that extra call to work with the entire team?
For me and for my team here in Tennessee, we were really excited. I mean, in the suicide prevention world, any support that we can kind of give other states to have this real-time data tracking, we see it as really, really important, because in the suicide prevention world, there's so much of a data lag that really, inhibits prevention programming and services. And so any help that we can provide other states, and as well as anything that we can learn from other states through kind of questions and getting that ball rolling within ourselves is really, really helpful.
Wonderful. And Jane, what were you able to do with the learning that you received from Brittany and from the Tennessee team? How were you able to implement changes based on this peer sharing?
Okay, so as I mentioned, our epidemiologist who works with our Essence data and our communications person who supports sort of our overall injury efforts, after meeting with Brittany and getting the response packet, we've been able to set up sort of an email alert system, as I mentioned earlier, with our adolescent school health providers. And then we've created a training packet too around, what is syndromic surveillance data, which is a little bit kind of tricky, but in a very plain languagey, nuanced kind of way to do some training for the school personnel on what they're receiving, what is the meaning of these alerts, etc. And then being able to, we have gatekeeper training going on in the community and other sort of, type. So it's not just QPR, it's, assist and safe talk and other modalities or approaches like that. So being able to, pair those resources with, a particular region of the state and push out some of that with, with those sort of alerts. And the alerts are just getting ready to start now, but we've got similar, and Brittany, I'm not sure because I haven't seen the official, the response plan, but I know that Jason definitely used that as a guide, but ours does differ some from yours as well.
Wonderful. That's great to hear that your alerts are going to start soon. And you've mentioned a little bit about the QPR and switching your focus. Nicole, could you speak to us a little bit more about that and what that experience has been like, also collaborating with Tennessee?
Sure. So I took over as the head of the suicide and self-harm prevention right when we decided to start switching over to doing QPR. And that's been very fun and a new challenge for me. So far it's going extremely well. We have trained about 83 individuals, and we've got another training this week on Thursday, and then another one in June. We're hoping to get more funding and work towards scheduling more in the future.
Wonderful. That's great to hear.
And Maria, just to chime in, so our Bureau does not do QPR. One of our CSLC partners is actually the trained, certified QPR provider. And so what we've been able to do is they're the ones who went from in-person training to virtual. And so we are promoting those trainings. We're finding additional resources to support those trainings and figuring out, how we can spread this around the state. And I'm sure, Brittany, I think you've said this on other calls, but just how virtual training allows, better spread, more people to be able to access the training since, we don't have to physically go to one place. And it has been, approved, the virtual training has been approved by the QPR, creators of the model, et cetera.
Wonderful. Brittany, could you tell us a little bit more about your experience in moving to a virtual QPR? And for everyone who is not familiar, QPR is Question, Persuade, Refer. And it's one of the evidence-based programs that many of our states are using. So Brittany, could you tell us a little bit more about what that process was like, and then also how you helped the other teams also think about moving into a virtual space?
Yeah, similar to Louisiana, we have the same kind of process here with my program, and these alerts really help us target areas in the state that may need suicide prevention gatekeeper training such as QPR, and really who provides those trainings within our state is our CSLC partner, Tennessee Suicide Prevention Network. So we have an entire network across Tennessee who has 9 regional directors that cover all 95 counties that provide suicide prevention gatekeeper trainings for free to the communities such as QPR. So we're really using these Essence alerts to really target those areas. And through moving to a virtual format, it's really allowed us to kind of infiltrate rural communities across our state, which is a huge focus for our comprehensive suicide prevention grant that we just received from the CDC. We have a lot of rural communities across Tennessee, so being able to provide these trainings in a virtual format really allows us to reach people that we may not have been able to reach before, as well as we're just seeing an increase in engagement and participation overall because people can kind of just join the trainings from their living room or from outside on their porch rather than going and meeting in a group. And so it's really, really allowed us to expand this programming across our state.
That's great to hear. So I would love to hear a bit more from all of you about what you learned from your involvement with your peers, both regarding Essence and QPR, and how did it change your implementation of these programs based on your peer sharing?
I can go first. Through this process, it really kind of first made me kind of look back to the beginning of really developing this process through the questions that the Louisiana team asked me. I really had to go back to the beginning and go, why did we do this the way that we did? And it really has helped us examine who we're sending alerts to. It also kind of made us recognize that we needed that training component because I was spending a lot of time talking to either other states or just individuals across our state about Essence alerts. And so we are in the process of, developing a one-pager and some materials to be able to disseminate within local communities and with these alerts. So individuals can understand kind of what Essence is, what data it collects, and what we're doing through these response plans. It also helped us know that we needed kind of a subcommittee. So I lead a statewide suicide prevention task force team. And so we have now developed a Essence subcommittee because we are going to be expanding the surveillance across the lifespan to include individuals of all ages. And so we really want to make sure that we aren't limiting this data and that we are providing data to stakeholders and to communities across the state without necessarily creating fatigue or like email fatigue or any type of like overwhelming feelings by receiving this information every week. So it's really kind of helping us look at this in a bigger picture and to help improve this process overall.
Wonderful. Jane and Nicole?
Yeah, I mean, I think, as Jenny and you always say, Maria, share seamlessly, feel, or whatever, shamelessly, or whatever the expression is. I think that is really the value in this whole process because, yeah, just so many things. And Brittany, you were talking about how questions we asked really helped you think about things. And I think just your experiences that made us think about, and when you're like, oh, well, we didn't really think about that, it really emphasized something for us that we wanted to make sure we didn't get, a year from now when somebody asks us the same questions and we're like, huh? You know what I mean? So we kind of learned from your perspective on things that, you really wanted to kind of shore up now that you've been in, your process had been in place for a while. So that was really helpful for us. I think the other thing that I've learned through this is just the power of partnerships, right? Because it was just amazing how, and when I talk about just, not just our peers in this, but I think of the Children's Safety Network, so Maria and Jenny, as our peers as well, because when we were about ready to say, especially after all the hurricanes, the hospitals aren't responding, the emergency departments are tricky, but we've got this plan. And, and Maria and Jenny were incredibly supportive about ways we could, I hate to use that word pivot and, to this other package. So, and at that point, our suicide, because, we don't have a suicide prevention division or program really within our Bureau of Family Health or even in our Office of Public Health. But our stakeholders that are also part of the CSLC really stepped up just in terms of resources, and we can do this, and making themselves available to be able to, when we pushed out alerts and really pairing this and saying that these are the resources that communities need when we're seeing that they're having elevations in child self-harm. We're just starting with kids right now, so under 18, but then with plans like Brittany and those guys are doing to kind of roll it out to other populations and age groups as well. But right now we're just only going to be focusing on our Children's Safety Network population.
Great. Thank you so much for sharing your experience with peer learning today and really speaking to the importance of meeting regularly and sharing your experience, your questions, your challenges within the CSLC. I'm really happy to report that additional states from our suicide and self-harm prevention team have begun working on including suicide and alerts in their syndromic surveillance system. So we look forward to continuing this amazing work into cohort 3. Jenny, do we have any questions for our panelists that have come in through our Q&A pod?
We do not have any specific questions at this time, and I think I'll reserve the time to just ask more generally some questions of all of the team members when we get to the end.
Okay, great. Well, thank you all so much, and we really appreciate you taking the time to speak with us today. Great. So,
you're welcome.
Our next team is on our next example, on peer sharing is from the Sudden Unexpected Infant Death Prevention team, and I will be stepping in for Erin for this discussion as well. So in our previous example, it was great to hear about sharing within the CSLC, so within the states that are participating, but some of our states have adapted our model to use within their own states. And so I'm really excited to speak with Terry Miller from Georgia, who took the peer sharing model from the CSLC and used it in Georgia to address the sudden unexpected infant death. Terry is the Safe Infant Sleep Program Coordinator, for the Georgia Department of Health. She acts as the subject matter expert on sudden unexpected infant death and supports programs and activities designed to prevent infant mortality and improve birth outcomes. Welcome, Terry, and thank you so much for taking the time to speak with us today. Great. So, Terry, could you tell me a little bit about why you wanted to join the Child Safety Learning Collaborative?
Sure, absolutely. One of the main reasons is we just wanted to learn more about quality improvement. It's something that's always a part of our work that we're doing, and so we're always trying to find ways that we can just learn more. And this was an opportunity to engage in a project that was longer term. It was project-based, and so it was a way for us to hopefully get more information on quality improvement, more so than just, say, a one-time webinar. We're also looking forward to connecting with our peers who are doing the same work and having that ability to share with them and to learn from them and those kind of things. And basically just to have a space to problem solve, to hear about what other people do to address the challenges and to learn about what some of their facilitators are.
Wonderful. Can you tell us a little bit about the peer sharing that you experienced in the Sudden Unexpected Infant Death Prevention team?
Yes, our peer sharing within our particular group tended to be very casual. It was very fluid. As we talked about our projects that we are working on, oftentimes we'd also bring in past experiences or maybe a different project that we were working on that wasn't directly related to the CSLC. And so it gave us an opportunity to really just have robust discussions and to actually share with each other. One of the parts that I liked the best was I was working on a PDSA, a Plan, Do, Study, Act, and some of the other participants worked on or utilized the tools that were available that were different from the ones that I was using. And so it was great to see how those tools could be utilized in other settings, and it gave us different ideas.
Wonderful. How would you say that the peer sharing benefited your work?
For me, I learned that quality improvement doesn't have to be quite so rigid. I think I knew that, quote unquote. However, when I filled out my Plan, Do, Study, Act for this particular project that we were doing with our home visiting team, and everything didn't go exactly as I planned it on that form, I felt like, well, now I guess we have to start over. I'm not sure how we're going to do this. And it was actually through our peer sharing moments with the group where I was able to see a different way that we could still continue to do it. You just had to pivot, be flexible, the things that we have to do all the time in our work. And with quality improvement, I found that without even realizing it, I was being rather rigid and not as flexible as I would be when it came up to any other problem that would come up, or any other challenge. And so those are just some of the things that, one of the main ways for me that was really beneficial.
Wonderful. And for anyone who's not familiar with our QI lingo, the Plan, Do, Study, Act cycle are small tests of change. So it's the way that we figure out if we want to adopt a change, adapt it, or abandon it. So Terry's speaking to her small test of change in quality improvement language. So I understand that you created your own learning collaborative at the local level. Could you tell us a little bit about it?
Yes, absolutely. We started a hospital-based Safe Infant Sleep program clear back in 2016. We had 100% participation from our birthing hospitals. At the time, that was 84 hospitals. And about 130,000 births a year. And so we had a lot of participation and interest in improving safe infant sleep at the hospital level. And we continue to work with them to this day. And one of the things that becomes a challenge is keeping people engaged, finding ways that can help to refine some of the work that was done previously to guard against drift where people start to kind of go back to their old way of doing things. And so very quickly after joining this collaborative, I realized that this would potentially be something that we could do in Georgia with our hospitals. And the whole idea of peer sharing and having a group where every month we would get together and we would learn more about quality improvement, how we can apply that to our work, and then share with each other about where we're at in the process and the things that we're working on. And so we started a collaborative, we called it a cohort. We started a quality improvement cohort here in Georgia with 13 of our birthing hospitals. And I have an outside consultant that works with us, Dr. Sam Ward, works with us just to make sure that we're using research-based tactics. But we come together on a monthly basis to focus on the Plan, Do, Study, Act part of it, and to find the areas within each of the different units. We now work with pediatric units, NICUs, and well baby units to find what it is that they need to work on improving. Some of them just staff education. Many of them is about how safe sleep is being modeled in the hospital. And so we work on them, whatever they decide and they find that needs to be worked on is what we then target. So we do that since November of last year.
Wonderful. That's great to hear that you've taken our model and adapted it to your local setting. Could you tell us a bit about how the collaborative worked for the participants in your collaborative, in your cohort? And if you have any success stories, we'd love to hear one.
Yes, absolutely. We do have a success story that came about fairly quickly in the process. We have always utilized a crib audit tool, which is just a way for hospitals to look and see how the baby is sleeping while in the hospital. Is he on his back? Are there a bunch of cribs, blankets and diapers and those kind of things in the sleep environment, or is all that removed? And so it's a very common tool. It's used all over the place, not just Georgia. And what we discovered once while we were having one of our calls was after we had done a small presentation on quality improvement, we were going through each of the participants and they were talking about the different things that they were working on and challenges and those kind of things. And one of our NICU nurses stated, we have a habit of always having the head of the bed elevated. And they do it regardless of whether or not it's medically indicated. And in safe sleep, the baby is always supposed to be firm on a firm mattress and flat. And reclined positioning is not the recommended position. And so as soon as this NICU nurse was like, it's just a habit here, it's just part of the culture and it's what we do often, another nurse spoke up and said, oh my gosh, that's Teal. And then as we went along in the conversation and talking about, we've had many of the participants had similar issues, some more so than others. But as we talked it through, what we realized is on our crib audit form, we did not ever have a spot there for whether or not the bed was flat or if it was reclined or inclined. And so we had no way to gather data on if this was an issue in each of the facilities or their different units, and if it was, how we could work on trying to address it and to get it fixed. And so that was something that through the sharing amongst all the peers, it kind of clicked for us that, oh my gosh, we should be putting this on our crib audit data, our tools, so we can have that data so it can help drive our quality improvement efforts. And so that was just one of the things that came out fairly early in our efforts. And so now we have a revised crib audit tool and also the supporting documentation that's needed in order to back up that recommendation and to help educate on why it's important that we keep it flat. So that was one of the things that we learned from peer sharing.
That's great. That's really wonderful to hear that you have these almost immediate results from starting your learning collaborative. I wanted to ask one final question about the participants in your collaborative, if they're staying engaged, if they're continuing to work with you. You said that you started in November, so it's been a couple of months. So how is that going?
It's going fairly well, we feel. We started out with 13, and we were very honest with our hospital representatives that this was a new thing for us that we were trying, and so we were going to be learning as we go as well, as we go along, and that if it went well, we would do a cohort 2 and do a second round and use the lessons learned from this one to maybe make that one more robust. So we had our 13 participants, and now we're at 8 to 9 that are participating on a fairly regular basis. So not everybody attends the meetings every month, but we send out a recording. And so then usually we get follow-up messages and we share in that way. Because working with hospitals, we have folks that are on different shifts and they have different responsibilities. And so sometimes that can be a challenge, is making the actual meeting. And so we have a central location where we can share files, and we also have the recordings available so that those who can't make the meeting can attend. So at this point, we still have between 8 or 9 who are participating with us and going through the process. Most of our groups have already gathered their baseline data. They've done staff surveys, crib audits, those kind of things. We've created a lot of tools for them to use during this process that we didn't have created originally. So when we had asked people to work on safe sleep within their hospitals, we didn't have these tools created for them. So now we have those that we can share with others. So yeah, I would say that
we're pretty happy with the number of people that continue to participate, especially with the unique challenges that have been going on within the, over the past year.
Great. Well, I'm really happy to hear that you're continuing to work with all of your birthing hospitals and that they're collaborating with you on QI and you're providing with the tools for them. This is really wonderful. So thank you so much for sharing, and thank you for highlighting how you're taking the model of sharing within the CSLC and applying it within your state. We really appreciate it.
Thank you.
Great. Thank you so much. Jenny, do we have any questions specifically for Terry?
We do not have any questions specifically for Terry, but if the others would join, I do have some questions that I'd love to just elicit some response. So there was quite a bit of conversation throughout all of the teams about the importance of data and how you're using data. And so I'm curious about how you're collecting data. There's a lot of work that's happening amongst your teams where you're engaging partners and working across different systems. Can you share some examples of how you're collecting your data and then who that's being shared with and applied in your quality improvement process? And this can go to anyone, so.
Yeah, sure. I can go first. So here in Tennessee, we were fortunate enough recently to receive a grant from the CDC to implement a comprehensive public health approach to suicide prevention across our state. And with that funding, we were able to hire an epidemiologist in the department to really track our suicide data, which is huge. So he is the one who is responsible for really tracking all of that data. And then we partner with the Department of Mental Health and Substance Abuse Services as well as the Tennessee Suicide Prevention Network to gather data on statewide crisis line calls and crisis text line calls. And then through our CDC grant, we also developed a communication and data dissemination plan that outlines the frequency that we're going to communicate, the outcome measures, and the types of things that we're going to share with certain at-risk populations and stakeholders. So that's kind of how we're doing it in Tennessee.
Great. That sounds very organized and similar to what Terry shared about, creating some tools or mechanisms to help, really with that communication across partners. That's a great example. Are there any other examples from either Louisiana or Georgia of how you're collecting data and then applying it, or who is applying it to your quality improvement work?
Jenny, this is Jane. Ours is very, very simple at this point because since we pivoted back to the gatekeeper training, we are testing. So we talked about QPR today, but there are other resources. So there's Assist, and we're using another model, which is a self-directed sort of online gatekeeper training. So we're looking at really simply, uptake for those different modalities and then people's satisfaction with those to see just, because we're offering it in schools, we're offering it in the Department of Children and Family Services, and then for something totally different that's not related to the Children's Safety Network, we're working with people that work with older adults, but really we're testing, our test of change is sort of, moving to virtual kind of gatekeeper training, and what are we learning from that? So, every time we schedule something, did people that signed up for it and registered show up? What was the feedback from those folks? And then putting it back into, okay, well, what do we need to do with promotion of the next event? Or how do we want to use these particular licenses for the self-directed training? So we're mostly using it in a processy way to really figure out what is the most efficient and effective way to roll out these resources. So right now that's where we're focused. We do have, as obviously, our talk today was about Essence and using syndromic surveillance data. We, as I mentioned earlier, are not a suicide. We're not responsible for suicide prevention in the state in terms of that. Charge lies with our Office of Behavioral Health. We don't have any suicide-specific grants, but we do have the National Violent Death Reporting System grant from the CDC, which actually tracks suicide. So we have, suicides, and then we have other means of looking at sort of suicide attempts, ideation, self-directed violence, et cetera. But right now, for the Learning Collaborative, it's mostly just using our data to improve sort of the offering and how we can get more gatekeeper training available around the state.
That's great, Jane. Thank you. And that's just a wonderful example, too, of the types of data. I appreciated you talking about your processy kind of work, and I think that certainly is a lesson that throughout the work of the CSLC continues to come to the forefront, that there are so many different types of data, and frequently when we're working towards really maximizing our injury and violence prevention work, we're thinking about those outcome data of reductions in fatalities and injuries and hospitalizations, but that could take quite a long time for that data to be available. And so it's really learning using these small tests of change and what more proximal data is available. Those were some really great examples. We've talked a lot today about the adaptations that your teams have made in response to a really challenging year. And I'm curious, as you're moving forward, how are you going to measure what's really been working and consider about how to return to, quote, normal life and what you might take with you once normal life resumes? There any?
I can go.
Go ahead, Brittany.
Fortunately, again, I'm going to talk about our CDC grant, because through that grant we are able to work with the Centerstone Research Institute to do extensive program evaluation. And so that's going to really kind of guide our work in the future. What we've kind of learned here in Tennessee through the last year is that some of the processes and adjustments that we've had to make because of this COVID-19 pandemic aren't all negative. We have seen an extreme increased engagement and participation within our stakeholder task force team. So we do continue, we plan to continue to still offer that like in a virtual format. We're also planning to still offer QPR trainings as long as the QPR Institute permits that through a virtual format, as well as in-person format and small group settings. So those are some of kind of our initial next steps, but we'll kind of acclimate as we get kind of our program evaluation results.
Fantastic. Another great example of using a multitude of different data points to continue to just inform your process as you're moving forward and be very aware of kind of the micro changes and micro opportunities that you have.
And then Jenny, this is Jane too. I know Nicole and our team, we've spoken because so the CSN and the Science Health Palmer has been a springboard for a lot of other work that's now happening in our state. So we're applying for funding to continue sort of gatekeeper training beyond maybe this cohort, and really starting to look at the evaluation aspect of it. So really trying to figure out from the, working with the participants who've gone through the process to see how they've applied their learnings there. And then of course we'll always be tracking the more, the injury-related outcomes as well, but also just really trying to figure out the application. So right now we're focusing on, spread of the evidence-based model, and then sort of applications of it once we have sort of lots of people trained around the state. So we are talking about that. But the important thing is really, I think, too, how what started out as a small project has really, been a catalyst for some other work that's going on in our state.
Outstanding. Thank you, Jane, also for, sharing again that perspective of starting small with the, the ideal of moving to a full spread, but understanding that, doing these smaller focused tests of change and really building your model so that it can become scalable is a great springboard to be able to advance your work more effectively. As we are about to transition back to just closing out the event, I just wanted to give everyone an opportunity, if you were to share one piece of advice for any state or team that might be considering joining Cohort 3, what would that be?
I guess my advice. would be to do it. It really provides a lot of opportunity for peer learning and sharing, and it gives the opportunity to kind of work with, other individuals who are doing the same type of work that you're doing across the nation. It really helps you think about your processes and the things that you're doing in a different way.
Yes, and I was going to say pretty much the same thing, is that it's definitely worth the time. I know 18 months when we were first considering it felt like a long time, and we wanted to make sure that we would have, the ability to participate in the way that we wanted to. And so at first, having it be an 18-month long process felt a little daunting, but it turns out it's not, and the information that you receive and the ability of sharing with your peers and learning from others is just well worth it.
Ditto. I mean, I think, as I mentioned, it's been a catalyst for a lot of other work. What started out was, how are we going to do this? There are no resources, but the team at the Children's Safety Network is incredibly supportive. Terry, I think you mentioned about how your PDSA didn't look the way it wasn't as clean as you wanted. They kind of take you through the really practical approach to performance improvement and really learning, and it's just a tremendous resource that can start all kinds of other great stuff in your state as well, and foster some great partnerships.
Awesome. Thank you very much for that wonderful commentary and advice. We're going to go ahead and switch to just some closing slides. I want to thank you all so much for joining us today and sharing your experiences and insight. As was noted, we do have an opportunity for others to join our Cohort 3, and very briefly we'll be providing application materials through the CSN website and other mediums of communication in late June, and then the application process will extend through the summer with the November 2021 kickoff with accepted teams joining us for a full collaborative learning session. And at this time, you should have seen a survey launch on your screen. There's an opportunity in that survey to also let us know if you're interested in learning more about the Cohort 3 opportunity, so we can add you to our newsletter and other communication resources. But again, you'll see that information on the website. And I want to thank all of our presenters once again for an outstanding presentation. We so appreciate your contributions to helping to really move the needle on child and adolescent injury and violence prevention. And your work is helping to inform our work, which we then can help to spread this information and best practices nationwide. So thank you all very much, and have a wonderful day.